What are the diagnostics? What kind of hints do we need to show us that there might be a problem? How do we analyze you in particular? In other words, what the heck do all those tests mean and why do I need to spend that money? That's the bottom line, right? Go ahead, next slide. So this is a slide from last time, and we said this cannot happen. It just can't. Because most of this stuff we can prevent if we know where to look and if we know what to do. Next slide. Now, I said, what do we measure? Where do we go? This is probably just a brief look at all the stuff. Do we measure central obesity? In other words, do we get a CAT scan of your middle to see where your visceral fat is? Is that important? Probably. Your triglycerides, your PAI, your MMP, your ADMA, fibrinogen, pancreatic beta cell apoptosis. We talked about that. All those things. But not only what do we measure, but how do they fall in the scheme of things? What's really important? And I will tell you, we don't know. I'll show you what I think. I'll explain again this process so that we can at least analyze to some degree what are the really important things to analyze and take a look at. But in the end, if you have to look at all this stuff, well, you'll just go to bed exhausted and poor, right? So the question then is not only what do we measure, but after we give you medication, after we change lifestyle, after you have not had ice cream for 6 months, what do we measure to show you success? I don't know. That's the honest to God truth. I will show you what we think we know, but I will share with you that I have a lot of doubt that what we're doing today will be what we do in 5 years. Just like 5 years ago, we were doing something completely different. If you'll recall, the old way, we did angiograms on everyone, right? We stuffed dye into them, we looked at angiograms. Doesn't help. It shows you what the flow is. We know the flow is fine. Not the question. What's that wall look like is really what the question is. And an angiogram doesn't answer that question. I'm going to show you what the CIMT does and how that might answer the question, but even it is not as perfect as we'd like. But you can see how we've gone from a totally invasive test to a test that we can do here in the office, and you can see for yourself, very important. But in the end, where will we go? I don't know. Will there be a blood test? I don't know. I can show you, and the Cleveland Clinic has some very, very new stuff where we can be right on the cusp. And what it tells us is, oops, there might be a problem. But it doesn't tell us where, and it doesn't tell us how to fix it. Okay? It's important to know that there's a problem, but not if you can't fix it, because then you just raise anxiety levels, right? Yeah. So you can see where this is going. I'm sure that those people who had bad angiograms thought they were going to die in a minute, and yet it was a meaningless test. So I think it's important that we put this in context, is my point. This is not to increase your anxiety level, but really to give you control, a better understanding of what you can do to make your life better. Next. Now, when we look at the risk of heart disease, I will tell you that there are so many things. OR means odds ratio. ApoB over ApoA. ApoB is that protein on top of the LDL molecule, ApoB on the HDL molecule. So that's looking at bad over good. So the higher that ratio, the greater your risk, 3.25. Now, if you go down the list, diabetes, and it's there in the mirror, but it's over 2, hypertension, abdominal obesity. Alcohol intake, though, is less than 1. In other words, drinking a little alcohol is a benefit. Exercise is a benefit. And, of course, eating fruits and vegetables is a benefit, just what you needed to hear. But what does it mean when I'm stressed? Stress has a greater risk than smoking. Now, we used to call that stress. We used to call that hyperpersonality, that type A person, right? But really, it doesn't have to be that you're such type A. Life's stresses. Your neighbor just got foreclosed upon. If you think that doesn't stress you, you're wrong, right? Your children just flunked out of college. That stresses you. The bank goofed up everything. You didn't do anything wrong. But life stresses today are so much more and so much more immediate that does explain, I think, a lot of the illness that we have, and that increases all those inflammation factors that we talked about last week. Next, please. So when we're looking at risk factors, there is a slew of them. And we're going to concentrate on just a few of them, particularly periodontal disease. I'm going to talk about family history a bit, abnormal lipids, hypertension, and diabetes. But you can see even migraines, and interestingly enough, migraines particularly in men. Collagen vascular disease, also significant increased risk. That would be the person with rheumatoid arthritis, the person with psoriasis. And here's an interesting one, that the studies haven't been done, but I'm sure this is true. They all go on, not they all, many of them go on those, you've seen them, those biologics, those very expensive drugs that can be injected. You've seen them advertised on TV, Remicade, Humira. Have you seen that stuff advertised? Miracle drugs. And I think it also decreases the risk of heart disease because it decreases tumor necrosis factor, which is a big inflammatory marker. And what's interesting is that people on those drugs don't get heart attacks. Now, I'm not suggesting that we all go spend $20,000 a month on a tumor necrosis factor inhibitor, but it just shows you how interrelated all these disease functions are. It's not just a simple medicine, treatment, you're done. Next, please. This is more risk factors just to show you. PCOS is an interesting one because not only polycystic ovary disease, but polycystic ovary disease is a risk for diabetes. The siblings of young women with polycystic ovary disease obviously have a risk of diabetes because the person with the disease has a risk. So we now know that males who have sisters with polycystic ovary disease have an increased risk of heart disease. Does that mean they're going to have a heart attack tomorrow? No, but that might mean they may want to take some precautions. Next, please. So the usual and customary is not enough. What did everybody used to do? Everybody used to make diagnosis by cholesterol, right? What's your cholesterol? And we've talked about this a zillion times, but I wanted to give you some data. 77% of those with coronary artery disease have what used to be considered a normal LDL, less than 130. 77% were sent home from their doctor's office and told they were normal. 45% of those people with normal HDLs, that's the good stuff, were found to have coronary artery disease. And 61.8% of those with coronary artery disease have normal triglycerides. Those are incredible data. Now that's the usual and customary thing that you get on your cholesterol. You know those four things, total cholesterol, LDL, HDL, triglycerides. That's what most doctors get. Poof, you're done. We're missing more than half of the people with disease. We've not asked the right question. And of course, some of these people are probably being treated when they don't need to be, and vice versa. The point is, the old way is just not sufficient. Next, please. So I wanted to look at diabetes, and what you're going to see is a whole slew of slides here. But I wanted to impress on you the incredible risk that diabetes imparts as a risk for heart disease. You got diabetes, you have heart disease until proven otherwise, and pre-diabetes needs to be treated because even in pre-diabetes, you start to have issues. The most important thing I want you to remember is abnormal endothelial function. If you will recall, the endothelium is that layer, that fine layer of cells that lines the blood vessel wall. It's the protector. It's the guys at the gate. If that wall breaks down, all bets are off. Okay? It's like the border is open. The bad guys can come in. If the border is closed, the bad guys might be able to get in, but it's a heck of a lot harder. That is the first line of defense. And when that defense goes awry, for no other reason than you have pre-diabetes, that is an incredible risk. Now that doesn't mean that you're going to have a heart attack on day one, but imagine if that border now stays open for 5 years, 7 years. Way before still your diabetes is diagnosed, you may have a heart attack. And in fact, we saw that data, didn't we? We saw that half the people get their diagnosis of diabetes. When? When they have their first heart attack. That's just not appropriate. That's just wrong, especially when we know what we know. And the majority of those people have endothelial dysfunction. We know that diabetics have abnormal lipids, usually increased triglycerides, small LDL, low HDL, and they glycolate. Glycolate means that they put a glucose on it. So they put a glucose on their LDL, which increases the half-life. And remember we talked about the LDL and had it have a long half-life? So that means that the bad guy hangs around longer. And it shortens the half-life of the good guy. I know, not our friend. Next slide, please. So moving on, there are autonomic irregularities. In fact, that means funny heartbeats that can have a problem. The decreased bioavailability of nitrous oxide. Nitrous oxide is that very important enzyme that's made by the lining of the blood vessel wall. Key, I want you to remember nitrous oxide. That endothelial wall is a barrier and it's got spears in it to help protect itself. It makes hormones and enzymes for self-protection. So it's not just a border, it actually has inherent in its systems the ability to improve its own protection. The diabetics have increased secretion of vasoconstrictive endothelin 1. Vasoconstriction means that the vessel is made smaller. That then leads to hypertension. Now, how many diabetics have hypertension? Almost all diabetics have hypertension. We're going to talk about hypertension and its inherent risk for heart disease, but also how it breaks down that blood vessel wall and it provides increased shear stress. But even if your hypertension is not primary, if you have diabetes, this is what happens. The basement membrane is leaky. That's again, that endothelial function is leaky. And remember we talked about measuring proteins in your urine because of that leaky membrane. Go ahead, next please. We measured this in your urine and you'll see that goes off, that lab goes off to the Cleveland Heart Lab. We talk about the MACR, that's the microalbumin creatinine ratio. So how leaky is that membrane? And there's a specific number that we look for. That is our first hint about endothelial function. Cheap, easy. Leave me a urine, poof, I can tell you. And I will tell you that hypertension in and of itself is its own risk for leaky membranes, and diabetes is as well. You don't want leaky membranes. The other test that we're going to be doing in the office to test for leaky membranes, I'll just interject this now, is a test called EndoPAT. And so after July, you'll come in and you'll put your fingers into this device. It's really cool. And what it does is it indirectly measures the nitrous oxide levels. So we pump up your arm, we cause vasoconstriction so that the blood vessel is closed. We then open it up again and we see how much of that nitrous oxide gets out into the system because nitrous oxide causes vasodilation. If in fact your blood pressure goes back down again and those blood vessels open, we can measure that. We assume that your endothelial function is adequate. I'm happy to tell you mine is adequate. Absolutely. The diabetic has a state of chronic inflammation with increase of pro-inflammatory cytokines. Next, please. And we've all talked about inflammation over and over and over. Interleukin, PAI, tumor necrosis factor. In this office, we actually measure PAI, and I've been measuring it for over 10 years. There were some articles a long time ago about plasminogen activator inhibitor, PAI, being an early predictor of diabetes, vascular-related diabetes, or the diabetic that has a vascular problem. And indeed, many of you have an elevated PAI. If you do, I've told you that. I measure it. And it's, once again, another risk factor. It tells me that there is that pro-inflammatory state going on, usually as a result of your diabetes. It goes on to talk about the exception is adiponectin. There's one of these hormones that actually is good, and that's adiponectin. We're going to talk about that more when we talk about nutrition and fat and stuff. The other important thing that I want you to remember is that there's a chronic increase in oxidative stress in diabetics. Oxidation is kind of like rust. How rusty are you? And you see when things oxidize, they turn rusty, right? So I think it's a nice analogy. It works for me. Oxidation is enhanced by diabetics. It's enhanced by age. Sometimes you can't do a lot about it, but smoking definitely increases oxidative stress. And so does diabetes. All those things just contribute to the aging apparatus. Next, please. You can see this goes on, and what I'm trying to impress on you is this is just diabetes. We haven't talked about any of those other things. This is just diabetes, even pre-diabetes. That's why I'm so insistent on you treating pre-diabetes, because it is an issue. It isn't something that you want to just see what happens. I'm not interested in waiting. So there's increased production of the superoxide radical, which is another oxidative reactive species. And tissue damage is due to an increase in white blood cell accumulation. And of course, there's the increase in the thrombotic state. The thrombotic state is the clot state. 80% of diabetics die to thrombosis, stroke, heart attack, something like that. Even a thrombosis in their leg. How many have you seen diabetics lose their leg? Because they have a thrombosis, there's no blood flow to whatever part of the leg, and they've had to have their leg amputated. I mean, that's just the worst, right? Thrombosis. So increased clotting, why? Increased inflammation. It all gets back to last week's lecture. But these are the kinds of hints that we have. These are the diagnostics. The dysfunctional endothelium, this gets back to the dysfunctional endothelium that we were talking about earlier, that sets up all those inflammatory markers, that sets up the probability of a thrombosis, right? Okay, next please. And again, there's an increase in heart failure. You may have heard me talk about a stiff heart, diastolic dysfunction. That is found in many diabetics. It doesn't cause a heart attack, but it is one of the reasons that heart doesn't pump as well. So a stiff heart, if you start from here and you can't push as much, you don't get as much blood flowing forward. So a stiff heart is not conducive to good blood flow. It's not the end of the world. It's treated with calcium channel blockers largely, and it can be treated. But it tells you again that there is some dysfunction in the heart. Go ahead, please. Hypertension. Again, these are the basics. You don't have to do much. A 2-hour glucose tolerance test in this office doesn't cost you anything. Check your blood pressure. Doesn't cost you anything. So far, 2 of the major predictors or diagnostics for heart disease can be found in your doctor's office virtually for nothing. But they're important to know. Hypertension is obviously very, very prolific, 31% of Americans. What defines hypertension? This is kind of an interesting story, because indeed it was just a story of epidemiologists. The epidemiologists looked at data and they said, oh look, more people die with a high blood pressure than a low blood pressure. And they made the cutoff 140 over 90. It was just an epidemiologic look-see. It had nothing to do with physiology. It had nothing to do with anything except who died. And because so many people die of heart disease, it actually has stood its time. So that blood pressure continues to be what our cutoff is. But let's be clear. Some people, that's too high. In a diabetic, that's probably too high. I can tell you that there are some people, I don't know of anyone where that blood pressure is too low, but you must go by what the patient feels like. In general, we like a blood pressure a little bit lower. There have been tons of studies done. Is it better to have low rather than medium low? At one point we thought yes. We're not so sure anymore. One more thing that we're not so sure about. In general, we believe that diabetics should have their blood pressure lower, and that it might take more medication to treat that, given all the things that we've talked about. But indeed, if your blood pressure is giving you a headache, it's too high, right? If you look at your brain and you've had tiny little infarcts or tiny little strokes caused by high blood pressure, it's too high. If you stand up and you fall to the floor, it's too low. These are common sense. But in general, that old 120 over 80 still probably rings true, and that's a good goal. Now, when should you monitor your blood pressure? That's another important thing. First of all, doctor's office blood pressure is always too high, and I think that's an obvious, because most doctor's offices would make my blood pressure go up.
Yes.
Indeed. But here, I'm hoping that that's not the case. Come in, have a little wine, sit down, we'll take your blood pressure. But I think it's still best to take it in your life. So I say, if you're a truck driver on the 405 freeway, you got high blood pressure when you're on the 405 freeway, and coming into this office is probably the nicest thing that happened to you all day. If you had to run your kishkis off to get here and you're exhausted and you're huffing and puffing and you walk in here, your blood pressure may be a little up. Common sense, right? Generally speaking, blood pressure will always be higher in the morning. Why? Simple physiology. All those hormones that wake you up in the morning, they make your blood pressure go up. More heart attacks and strokes occur at about 4 a.m. When those wake-up hormones are getting going. That's when my mother had her stroke. So blood pressure, if it contributes at all, and it probably does, even if it isn't the causal factor, it's probably a contributing factor, it's not a good thing in the morning. Hence, we have changed some of the way we treat hypertension. And many times I've told many of you to take your blood pressure at night, in your blood pressure pills at night. We find that the half-life is such that you get a better dose or a nicer level early in the morning. It's better coverage. Of course, that's all individual, and some people can't remember to take their pills at night, so that's kind of a useless thing to say. But it can matter. It can make a difference. And so if you're taking your blood pressure, don't take it just once a day, once a week, always at the same time. Make it random so that you can have an idea. The other thing that you should know is that it is normal to have blood pressure that is not the same. In fact, if your blood pressure is always exactly the same, you're sick. Seriously, it's not normal to have exactly the same blood pressure. So when you call me and you go, oh, look, it's all over the place, and it's varied about 10 or 20 points, that is normal. If you said my blood pressure is 120/80 every time I take it, that's not normal. Okay? Pulse will also vary, depending upon what you're doing, what you're eating, the movie you saw. If you just saw, whatever scary movie you just saw, your pulse and blood pressure will go up. Pain makes blood pressure go up. Anxiety makes blood pressure go up. So it all has to be taken in context. That said, high blood pressure is still high blood pressure. Too much pressure on the system. Too many shear forces. So they define pre-hypertension, and all those things are just definitions. Again, it has to be about you. If you've got tons of other risk factors, if you've got diabetes, if you've already had a heart attack, goodness gracious, blood pressure is important, right? If you're 90 years old and you've never had a problem in your life and your blood pressure is 140/92, no one is going to go crazy. Does that make sense? It has to be taken in context. Next, please. There are many endocrine causes of hypertension. Sleep apnea is an endocrine cause of hypertension. Insulin resistance and diabetes, as we talked about, is a cause of hypertension. I thought one of the things that was really interesting is what insulin does to calcium losses inside the cell. And it seems that there are some changes in calcium flux, and indeed that can increase vasoconstriction. Again, that constriction increases blood pressure. So there's so much going on here, isn't there? So how can one medicine, one intervention change the world? It doesn't. How can one medication, one intervention change everybody the same? Clearly, it doesn't. And we don't understand these very microscopic things. We're not measuring intracellular calcium. These are research tests. We think this is what's happening. But indeed, in the real world, we have no means of testing those things, at least not today. We're not Dr. Spock yet, or whatever, Bones. Was it Bones that used to take that thing and go up and down everybody and determine what was going on? Next, please. We're just not that sophisticated. Hypertensive have increased excretion of calcium in the urine, and there's some interesting thoughts about vitamin D deficiency leading to an elevation of PTH and intracellular calcium, leading to obesity, insulin resistance, and endothelial dysfunction. Who would think? Vitamin D is one of those fascinating new things. It is the new thing, isn't it? Vitamin D is present on every single cell in the body. And you'll see, I'll mention it a little bit later in terms of of vitamin D deficiency and its risk. I don't know. And in fact, there's so much literature that contradicts each other that it's hard to know. But there is no bad thing about making your vitamin D level reasonably normal. So just do it. Just do it. We may learn in the end that having too high a level is not helpful. I didn't say do too much, I just said just do it. What we do know is there is a direct association between those people with normal vitamin D and high vitamin D and good health. Smoking, duh. So the odds ratio of developing disease in smokers compared to non-smokers is 2.95. That's pretty significant. It's not the end of the world, but it's significant. So don't smoke, duh. It is probably true that secondhand smoke does cause a problem. I don't think it's important if you occasionally go to a restaurant and you smell secondhand smoke, except it smells bad, ruins the food. But if you live with someone who is a constant smoker and you're constantly breathing that smoke, it probably makes a difference. But I don't think in passing, that's why I think that the rules about going to your park and not smoking, those are kind of ridiculous. It's not very fun to smell smoke, but they're not killing you in passing. That's the honest to God truth. That said, you want to avoid it if possible. Next. Now, I do want to talk to you about periodontal risk, and I've asked many of you for the name and number of your dentist. If you haven't given that to me, I want you to do that. We're having a lecture for dentists in July. This is a hidden treasure of information. Patients who have periodontal disease have a 25% increased risk of coronary artery disease. That's huge. And we have not looked. In fact, most dentists don't even know to look. Again, business is business, and if you're too busy filling cavities, you're not looking for periodontal disease. And periodontal disease is pretty boring to treat. It's not a moneymaker, quite frankly. It's pretty boring. We're going to talk about it, and you guys are going to be so educated about it, you won't have a problem. And I'm going to educate your dentist about it as well. That said, it is pretty significant cause of these inflammatory markers. 3.8 times more likely to have had a heart attack if periodontal disease is present, and you're 2 times more likely to have a stroke. We know that it increases that CIMT, that blood vessel wall, and I'm going to show you that in a minute. That's pretty damn significant. Next slide, please. Very significant, I think. That plaque-2, that's one of those enzymes that we talked about last week, one of those inflammatory enzymes. Elevated in periodontal disease, significantly elevated. And of course, what you really want to know is, so after they clean me up, does it go down? And the answer is yes. 37% of those people with no other risk of heart disease had elevated plaque-2 levels and heart attacks. Imagine, you've done everything possible, your cholesterol looks great, but you forgot to brush your teeth a couple times. Who thought, right? Your mother told you, remember? Now, we can actually start to measure the source of the very bacteria that we think caused the problem. So there's a DNA test, and I'm going to inform your dentist about it so that they can get in on the program, because it has to be sent from your dentist's office. Politics, but that's okay. We'll involve them. But indeed, wouldn't that be nice to know you've got periodontal disease, you can take an antibiotic, you can make it get better, and then you can do things that can actually make it never come back? And that doesn't cost any money either. Very simple things to do. And it's such a big hitter. Between diabetes, periodontal disease, smoking, and hypertension, you almost got it covered. And yet those things go really very much unattended. We do not diagnose diabetes early enough. We miss hypertension because we go to the doctor's office so seldom and people don't monitor themselves. Smoking, well, that's its own story. And this is so simple. Periodontal disease. So again, if you haven't given me your dentist's name, please do. Next. Now, I want to talk about all of these diagnostic methods that we use. We've talked about measuring sugar and 2-hour glucose tolerance test, because that's how we measure for diabetes. We measure blood pressure, diagnostics in your dentist's office, and of course, all I have to do is ask you if you smoke. That's the diagnosis for that. Many of you have had the CIMT, and I told you that mine is positive. I will also share with you that my numbers are fabulous now. My LDL is 30. My HDL is 60. I'm so flippin' good. I've lost weight. I look good, relatively speaking. Better, not good, better, getting there. My CIMT has not changed. And I just had it done on Friday. I almost cried. But it got me thinking. We have big studies. We take 500 people, 1,000 people, and we measure average CIMTs. At time 0, we treat them, and then we measure them at time a year later or 2 years later. Those big studies show changes. But as I went back to the literature and I started to look on an individual basis, it's much different. Very hard to document those changes. We're going to continue to monitor it for every one of you here. You can be sure. But I don't want to misinform you that, oh my goodness, you're going to see dramatic improvement, because I don't think we really know how much improvement and over what period of time. Those studies haven't been done. It's too new a test. This is how we measure. We measure your carotid, and we measure it right before the bifurcation. So we measure it on the far wall, which is that lower wall. And the reason for that is that these are just conventions of measuring. It seems to be a better place to measure. It seems to be more consistent. It's a convention of measuring. Next slide, please. This is a typical CIMT. Now what I want you to see is, you see where that little hatch line is? Can you see that that's a little bit hazy? That is the intima. That is that inner layer of artery wall that's inflamed. It's thick. Can you see that? It's thick. The layer underneath it that's a little bit darker, more intense, that's the adventitia, that middle layer. And what you need to know is that the cells from that adventitia and from the muscular layer below it are actually producing those inflammatory cells that move up into the intima and cause a problem. That's what I'm looking for. I am looking to see what your intimal wall looks like. I think that we have to be very careful with all our testing. There is no all or nothing. This is the cat's meow. This is the only thing. That's not honest. And I learned that truth. Now, I'm going to do more exercising, and I'm taking some different vitamins, and I'm going to see if I can't make the change. I want to know what does make that difference, and how do we measure it? How do I give you some assurity that what we're doing not only makes sense, but makes a difference? I mean, it's one thing if it makes sense, but you want to know, is it working? Right? Now, what we know is that the thickness, the general thickness of that wall does make a difference. Now, this is not comparing time A to time B. This is just the general thickness. So as you can see, we're looking at thickness of 0.6 all the way up to greater than 1. These are millimeters. And if you want to know your thickness, I'll tell you. I've told you, but nobody remembers those things. It's okay. But as you can see, in men and in women both, as it gets thicker, the possibility of having disease, coronary artery disease, increases. The thicker, the more inflammation. Makes sense, right? Next slide. The same thing as you'll see is true of strokes. This is another slide for strokes. Same. So vascular inflammation, when you see it, it's there. Now, some of my colleagues would tell me that I should be looking at every vessel under the sun, every single blood vessel. But Marcy says, let's get real. If you've got it, you got it. I don't need to spend any more of your money to tell you that you have it. If you have it, we need to address it. I don't need to go hunt it down everywhere, because that doesn't tell me anything more. Especially since I'm not going to necessarily always compare A to B and know that that comparison is going to show me effectiveness. If that were the case, then it maybe make more sense. But this test is important to know that you've got it. You've got disease and you got a thick wall and it's a problem. And then you need to know we got to do something. But at the point of treatment, is it important to know what is it today and what is that thickness tomorrow? I don't know that answer, in all truthfulness. I do not know that answer. And no, I'm not going to go test all your other vessels. I think that's a waste of your money. If you've got it, you've got it. I am going to be looking at your aorta. You saw in the new stuff that we're doing, we're going to do the ultrasound on your aorta. But that's not for this. I want to make sure you don't have an aortic abdominal aneurysm. So that's for a different thing, because you know the aneurysm is the little pouch, the little weakness in the vessel of your aorta, and that's a different issue, very often associated with heart disease and hypertension, but it's a different question. But I'm not going to go spending thousands of your dollars looking for how many places do you have disease. It's not relevant. You got it. And if you remember what we talked about diabetes, so much of this is microvascular, where we can't even see it. It's microscopic. So what am I missing anyway? And the answer is tons, because we don't have the instrumentation to tell us. So we're not going to waste money. We're going to find out whether you have disease, treat it the best we can. Okay? This is a very good indicator. Next. Calcium scores. Now many of you, we started doing calcium scores. This is another area of debate. Calcium score is just that. How much calcium do I have in my blood vessel? By the time you have calcium, you've had the inflammation for a while. I don't know how long. But does the calcium always go away? No. Is it important that it goes away? Not necessarily. If you have old inflammation and that artery is cold, it's not active, the inflammation is old, it's calcified, the plaque is stable, so what? As long as you've got good blood flow, so what? If you don't have good blood flow and there's so much calcium that it's impeding the blood flow, that's a different question. But otherwise, so what? You got it. You had it. And that's an important thing. And certainly you're at increased risk for heart attack and stroke because it says you've had disease, but it doesn't tell you the state of your disease at all. It just tells you you've got old disease. Now there's a lot of folks out there doing a lot of work on coronary artery scores, calcium scores. Particularly interestingly enough, right over at Harbor General Hospital. One of my friends is the head of cardiology there, and I talk to him quite often about this. So what does it mean? You've got a total score, okay. What if that total score is all in one clump? In other words, you got one big plaque versus you got plaque everywhere. Well, it means different things probably. Most of that plaque, what you'll find, is at the places where there are shear stresses, where there are bifurcations in the artery. That I can tell you. There are tons of studies now looking at comparing one calcium score to the next. I think it's important that if your score gets higher, it means something, but maybe it means that that soft plaque became old. Maybe it's a good sign. Again, we don't know it. We don't know. In fact, I have a patient whose calcium score went up. Of course, you know, it gives me the heebie-jeebies. I get nervous, but her numbers are so good and she has no inflammatory markers. So I think her disease just got old and that there was no new disease. I'm not changing her treatment. Does that make sense? So all these things have to be taken in context. If they're taken out of context, you can say just about anything. You know, just like a Twitter that comes across. You don't know what to make of it, right? So in this case, you got to put it in context for it to make sense. Next, please. This is another a study that was done on CAC testing, is calcium testing. And what they show is that 72 patients that had scores of 0 had 50% or more stenosis. That's the other side. It's not perfect, doesn't measure everything. More importantly, it doesn't measure soft plaque. So if you have ongoing inflammation, your calcium score could be 0. Again, it has to be put in context. Mrs. Smith has an HDL of 20. She has a plaque 2 that's elevated. She has a myeloperoxidase that's elevated. So what if her CAC is 0? It just means she hasn't gotten it calcified yet. It means that her inflammation is raw, it's new, it's active, it hasn't calcified. Again, if it's not taken in context, you get totally the wrong information. That's why you need a doctor. Next, please. This test has become, this is a new test. I think it's very meaningful. Test was designed at Cleveland Clinic, and it tells you there's a problem. Myeloperoxidase is an enzyme that we find inside that blood vessel wall. It itself generates many reactive oxidants, so therefore the fact that that particular enzymatic reaction is going on means more bad things are happening. It's not the result of many things, it's actually starting the problem. It's the crap. It's the substance. That reaction actually consumes nitrous oxide. Nitrous oxide is a very important constituent right inside that blood vessel wall to help that blood vessel wall dilate. Whenever you see nitrous oxide being decomposed, if you will, or being less of, there is a problem for increased blood pressure and for inflammation. Very important. What we know is that you have a elevated myeloperoxidase level, we got to do something. We must do something. It is not found in other inflammation. It's just not there. So you know white cells go up with everything, right? You got an elevated white count, you could have an infection anywhere. You have an elevated myeloperoxidase, you have a vascular event about to erupt. Case closed. Next, please. What this demonstrates, and this is very important because this shows you precisely what I've been trying to illustrate. What we know and what we measure is just not good enough. You go to the hospital, not you, somebody goes to the hospital. They have chest pain. The first thing we measure when you get to the hospital is an enzyme called the troponin. What's your troponin level? Troponin levels, as you see the green line there? Troponin levels start to go up about, between 3 and 6 hours after pain, and they peak in about 24 hours. But troponin is a measurement of a cell that died. It means you've had an infarct. It's an after-the-fact hormone. It's telling you what happened, not what's going to happen. That is the improvement. We used to measure what we call CPKs. That's that kind of orangey beige line all the way out there. But CPKs were difficult because it was a muscle protein and it cross-reacted with liver muscle proteins and brain proteins, and so it wasn't as specific. Troponin was much more specific, but it's too late. You already had it. You're in the cath lab getting your stent or your clot sucked out. You have your event. Who wants to find out after the fact? That's an oops, right? That's an oy vey. Now, you can see that there are other things that go up. C-reactive protein goes up, obviously. Myoglobin is a measurement of the heart muscle. This is all sign of muscle death. And there's this thing that sits out right over before 0. Do you see that? Before 0, myeloperoxidase goes up. There's, pardon the expression, shit going on. You better stop it, because it's going to happen. The studies from the Cleveland Clinic demonstrate that if you test myeloperoxidase in a patient that's gone to the hospital with chest pain and sent home, and their myeloperoxidase level is elevated, within 6 months, a huge number of them will have a heart attack or stroke. It's not offered at the hospital. My patients that go over there, we actually either go over there and draw their blood or bring them over here. We get the blood. And I've had 2 or 3 patients that have elevated myeloperoxidase levels. One of them already, it's down. Another patient had one, she had a TIA and her myeloperoxidase level was off the wall. It is a predictor. It's the accident waiting to happen. But it's nice to know that you can do something. Actose, the triglycerides help. Actose is such a good drug. It's the drug that we talk about for prediabetes. Everybody, poo-poos it, makes your ankles swell, boo-hoo. Stop and take your drugs. This drug really improves endothelial function. It helps improve HDL function. It really is a good drug. The pioglitazones, rosiglitazones are really very good drugs. The other drug that's been shown to immediately lower myeloperoxidase is Crestor, perhaps niacin. But you got to get on it. You got to stop the inflammation. Shut it down. You don't shut it down, it's a problem. Next, please. Fibrinogen, another inflammatory marker that we measure. And we just know that for every increase of 100 of fibrinogen, there's a 1.82 increase in the hazard ratio. Who's going to get a disease? We're not really sure where that all plays, but fibrinogen is an important thrombotic agent. It's an important agent in the series of thrombosis. So it tells us that something's going on. Next, please. CRPHS, another marker. This is the one that everybody likes to measure, but it's really just an observer. It sits around and it observes. It's like sitting out there and saying, oh, look, inflammation is going on, and it kind of calls the other enzymes into play, but in itself is not a part of the action. Myeloperoxidase and plaque-2 are part of the action. If you open up that clot, you'll see those enzymes right inside causing the problem. Okay? So it's a little bit different. It's not as specific. I see it go up a lot in people who are heavy. Plaque-2, also, it is a player. It is inside that plaque. It is inside that vulnerable plaque. It's elevated in periodontal disease significantly. It means go find the problem. It means there's shit going on. And it's pretty specific to vascular inflammation. Next, please. Plaque-2, again, vascular specific, and they're independent of other risk factors. So where I was saying that CRP is pretty dependent upon whether you're heavy or not, people that are fat have elevated CRP. People who have elevated plaque-2, doesn't matter. Again, you got it, you got to treat it. Next, please. this is a slide to show you how important it is. Regardless of blood pressure, and of course risk ratio goes up as blood pressure goes up, as you can see, blood pressure from an average of 113 to 113 over 30. This is systolic blood pressure, and those people with blood pressures over 130 is the third group. But as soon as you add the elevated plaque 2, look at the leap in risk. So you got hypertension and plaque 2, you're an accident waiting to happen. I mean, that increased risk is 7 times the normal person. And we're talking about a disease that's the most common in the world. So if you've got 7 times the risk of the most common disease, you got an issue. If you have elevated plaque 2, I have told you we have been treating it. If you don't, I talk about it, but it may not have had the same level of concern for you, or you didn't know what we were talking about. But with all these things, if you want to know what your levels are, we'll go over it again, okay, on an individual basis. Next, please. The MACR is what we talked about earlier, the measure of endothelial function. All it is a urine. How simple is that? Women need to have an MACR of less than 7.5 and men less than 4. I don't know why, we're just different. But indeed, that once that endothelium gets broken down and you measure it, you know there is a potential for a problem. It doesn't mean the inflammation has started, but the wall's open. The door's open. Got to close it. Next. Isoprostane is a measure of oxidative stresses that we talked about, smoking and diabetes being the 2 most common causes of oxidative stress. Things that decrease it are good exercise and go take a vacation, right? Next, please. The NT-proBNP. That's a measure of how good your heart is functioning as a pump. What's the squeeze? How good a squeeze is it? It's not really that specific. It can go up with kidney disease and some other issues, so it's not quite as good a test. Again, has to be put into context. But indeed, it tells you that the function is not normal. And remember we talked about diastolic dysfunction in diabetics? That can be a first sign that you better go check the glucose. A person starting to get diastolic dysfunction, you already know that there's endothelial dysfunction, and you better go check it out. Next, please. So in summary, the CRP is not causal, it's an observer. The plaque 2 is causal. The MACR measures endothelial function. Fibrinogen and MPO are the other 2. These are the inflammatory markers that we measure in you repeatedly. That's why those tests are done. They're done by Berkeley, they're done by Cleveland Clinic, and that's why we mark, that's what we're watching. We're looking for, do you have inflammation? Do we need to chase the inflammation? What do we need to do? And can we make that artery shut down? Those things I will tell you are the treatment markers that do make a difference. By lowering your plaque 2, by lowering your MPO, by lowering those markers, we can make a difference. Next, please. Vitamin D levels we talked about, and as I said, just take your vitamin D. Just take it. What the heck, right? Next, please. Sleep apnea, another risk, mostly of hypertension and heart disease. Little known problem, was really first discovered in 1965, but really the heart of a lot of abnormal cardiac function, probably because there are increases in the sympathetic factors, in those things that make your heart beat faster, because when your oxygen goes down, the heart comes to, the body comes to the rescue and wants to save itself. And in so doing, indeed, it increases all those stress factors. And so the heart gets beat upon a little bit more. So it seems to have an increased risk. It increases blood pressure as well. Next, please. Now, these are various kinds of ratios that we can monitor. I'm not sure how much I believe in the ratios, but this gives you some indicator. So you can measure ApoB over ApoA. You like to have less than 0.8 or 0.9. You can measure total cholesterol over HDL, and you like that to be less than 3.5 or 3.0. So you can look at these markers, and they can help you determine what your cholesterol looks like. But in the end, it's not those numbers, is it? It's the bottom line. It's, do you have inflammation? So if your number's normal, but you still have inflammation, it's not good enough. Genetics. We'll talk about this briefly. Genetics is the other causal thing. It's not an absolute, right? Just because you have the genetics doesn't mean you're going to get the disease, but it tells you, again, you need to look out for it. These are the genetics that we're looking for. Next, please. 9p21 is the most common genetic marker that we look at. what we know is that those people who are heterozygous, in other words, they have one of those genes. You know, you get two, DNA, double-stranded, so you get one from one parent, you have a 25% risk of increased risk, and a 49% increased risk of heart attack in the young people. But remember, heart attacks in young people are very rare. So if you increase the risk a little bit, it's still substantial because it's such a rare, you know, people at less than 49 or 50 don't have heart attacks very often, but those that do often have this genetic marker. That's the point of this. 23% of Caucasian and Asians are homozygous. That means they've got a double marker. And then, you know, those are the people who really, 102% increased risk of heart attack when you're young. So if you're a parent and you've got this NP21, and you're concerned about your kid because your husband or your wife, your spouse, also has maybe risk, it's a good thing to check, because obviously that's the person that's being not attended to. The 45-year-old young man who's out running track, who would never had a thought in the world that they could have a problem, may be just the person who needs to be evaluated, because it is a substantial increase in risk. Next, please. The LPA variant is a variant that has to do with the use of aspirin. You've seen the use of aspirin. One day it's good, the next day it's not so good. In some people it really does matter, and those are the people that have this genetic variant. If they take their aspirin, you can see that you'll see all the dotted lines. They're very protected. You can see the line that's up, that blue line. Those people are on placebo. They're not protected, and look at their risk of heart disease. Their heart disease risk is huge. You put them on aspirin, and as you can see, the red line comes right down. So those people's risk of heart disease can go away completely just by using aspirin. If you have that variant, I've told you, don't stop your aspirin. For other people, I think aspirin is important. Aspirin is important because it decreases the risk of cancer, and it still decreases thrombosis, but it doesn't have that overwhelming, risk. Goodness gracious, that's a huge decrease in risk just by taking, and it's just a baby aspirin a day. That's all they need. Next, please. KIF6 is a very debated genetic issue. The Cleveland Clinic doesn't believe in it. Berkeley does. Long and short of it is, if you've got KIF6, we think there's an increased risk. Equally as important, people who have KIF6 seem to respond very well to a statin. So it can tell you that if the patient has risk and you give them a statin, you're likely to get benefit. If the patient has risk for other reasons, 9p21, or they have other risks, diabetes and hypertension, and they're not KIF6, you might want to treat with more than one drug, because a statin is not necessarily helpful. That's really where that genetic marker makes sense. It's to those people who are negative who need additional treatment. That's really the more important part of that genetic risk. Next. LPA, this is the Jim Fixx protein, the guy who fell over dead. His father fell over dead while they were running track, even though they were fit as a fiddle and ran and did all the right things. Genetics. And at the time, he was not being treated except with diet. This is very hard to treat, but we can treat it with statins. There's some talk about statins plus using carnitine, and niaspan is the only drug that really lowers that LPA. In summary, it is important to evaluate every variety of risk that can contribute to heart disease and stroke. A lot of that risk, as you know, and as we've discussed, can be taken care of by treating diabetes, hypertension, and of course, not smoking. Exercise wouldn't be a bad idea, a lot of rest and less stress, all of those things that contribute to heart disease and stroke. Given individual risk, it is our job to continue to evaluate for ongoing inflammation. That is done specifically by evaluating laboratory, and we've talked about those inflammatory markers. After we've evaluated the laboratory, it is important to look for that inflammation, and we do that by looking at the CIMT, or that level of intima in the carotid artery. Old inflammation or calcification is not an indication of ongoing disease, but it is an indication that disease was present at one time. We must then go on to treat that inflammatory process, and that is the subject of the next lecture, when we're going to discuss how to minimize those risks, and then of course how to shut down that inflammation. Because again, this cannot happen. This is not allowed. No strokes, no heart attacks, not if you're a part of the Z Life. Thanks again for listening, and stay tuned for the next part of our heart attack and stroke prevention series.